This is the third video in the series on inflammatory bowel disease and will discuss Crohn's disease. Let's now talk about Crohn's disease. Crohn's disease affects the whole length of the gut from the mouth to the anus. Most commonly, it affects the end of the small intestine and beginning of the large intestine. Crohn's disease affects the entire thickness of the gut. About 80% of patients have involvement of the small intestine, 20% only the large intestine or colon, and 50% both small and large intestine. The main symptoms are severe stomach pain, diarrhea, usually without obvious blood, tiredness, weight loss, and fever. It can also affect other organs like the skin, mouth sores, joint pain, liver disease, kidney stones, and blood clots. Let's now talk about investigations. Blood tests done include full blood count, liver and kidney test, and tests mainly to look for nutritional deficiencies like iron, vitamin B12, vitamin D, calcium, magnesium. Optional blood tests would include the following tests to look for nutritional deficiency like folate, vitamin A and E, prothrombin time to look for clotting factor deficiencies, zinc, and phosphorus levels. Also blood test to look for C-reactive protein, which is a measure of the degree of inflammation. Stools test for bacteria and parasites, as food poisoning can have similar symptoms. Stools for calprotectin, which is a marker of inflammation of the intestines. Colonoscopy to look for changes in the lining of the colon and end of the small intestine that are suggestive of Crohn's disease. Also, tissues of the lining called biopsies are taken and examined under the microscope. Gastroscopy to exclude Crohn's disease affecting the upper part of the gut. Small bowel imaging including CT enterography, MR enterography, or small bowel imaging X-ray. These tests are done to exclude part of the intestine that cannot be seen clearly by colonoscopy or gastroscopy. MRI enterography is recommended for the younger population because there is no radiation exposure. Finally, video capsule endoscopy to look at the small intestine, provided there is no narrowing of the small intestine. Crohn's disease can be classified according to whether it is a low risk or high risk patient according to the criteria listed below, and the severity of disease using scores like the CDI, Crohn's Disease Activity Index. The objective of treatment is to ensure that there is complete healing of the inflammation of the intestines as confirmed by endoscopy and clinical remission. There are two aspects of management: treatment at disease onset and relapse or flare-up, and secondly, maintenance of remission. Medicines are used to suppress the immune system and thus reduce the abnormal inflammation that is causing symptoms. It will relieve symptoms and allow the intestine to heal. In maintenance treatment, these drugs are used to stop the inflammation from coming back. Treatment at disease onset or flare-ups. For low-risk patients with mild disease, a step-up therapy is given. Step-up therapy uses less potent drugs with fewer side effects. If patient does not respond, then more powerful drugs are used. For high-risk patient with mild disease or patient with moderate to severe disease, a top-down therapy is given. Top-down therapy uses more potent drugs with rapid onset of clinical resolution but with more serious side effects. If the disease involves the last part of the small intestine called the ileum and the right side of the colon, then a steroid called budesonide is used. Budesonide is a drug of first choice. An alternative is a drug called mesalamine. Budesonide is a steroid and it seems to be more effective than mesalamine. Budesonide is given for a maximum of 3 to 6 months because of side effects. Steroids suppress the immune system. Mesalamine is anti-inflammatory and appears to be not as effective as budesonide. If the Crohn's disease affects the left side of the colon, then the drug of first choice is a steroid called prednisolone. Second choice is a drug called sulfasalazine. If the disease affects the lower part of the colon, namely the rectum and the sigmoid colon, then rectal steroids in the form of enemas may be used as the side effects are less. This is called step-up therapy for management at initial presentation of a relapse, because if it is not possible to achieve remission, then stronger drugs called immunomodulators or biologics may be used, which I will discuss later. This table shows the management of Crohn's disease that is mild and low risk. An alternative to the use of prednisolone is budesonide MMX, which is a formulation of budesonide where the drug is released in the colon. So this table summarizes the drugs used in mild and low risk Crohn's disease. For patients who are at high risk or have moderate or severe Crohn's disease, a top-down therapy is used. And more potent drugs like steroids, immunomodulators, and biologics are used. This table shows drugs that are used in high risk or moderate or severe Crohn's disease. Steroids can be given either intravenously or high-dose oral. Steroids suppress the immune system. Immunomodulators are given either intravenously or orally, and they also suppress the immune system. Biologics are given either intravenously or an injection below the skin. They are antibodies that target or block and neutralize certain proteins that are involved in the inflammatory process. As you can see, immunomodulators and biologics are effective after a couple of weeks. In the interim period, steroids are given because they are faster acting. These are drugs used in the maintenance therapy of Crohn's disease. In maintenance therapy, these drugs are used to stop the inflammation from coming back. If remission is achieved with mesalamine or sulfasalazine, then these medications are continued. In patients with high risk or moderate or severe disease, immunomodulator and biologics are continued. Often, they have to be given lifelong as there is a high risk of relapse if stopped. In patients with low risk and mild disease, mesalamine can be continued as maintenance therapy, although it is controversial whether mesalamine is effective in preventing relapse. Maintenance therapy is to prevent relapses, as relapses increase the risk of complications, often requiring surgery. Complications of Crohn's disease include abscesses, which are infected pus-filled pockets in the digestive system, fistula, which are abnormal tunnel-like openings that form in the intestine and sometimes become infected, anal fissures, which are small tears in the anus and may cause pain and bleeding, bowel obstruction due to scar formation in the intestine wall, which may partially or completely block the intestine, cancer of the small and large intestine. There is a small increase in the risk of small intestine and colorectal cancer after 8 to 10 years of the disease. Hence, colonoscopy should be done 8 years after onset of symptoms and repeated every 1 to 2 years. Finally, malnutrition is not uncommon and is due to decrease in the absorption of nutrients by the intestines. Some mild Crohn's disease today can become more serious in the future. About 70% of patients with Crohn's disease will require surgery at some time. Surgery in Crohn's doesn't cure the illness but makes life more livable. Surgery is indicated if disease is not controlled by medicines or if side effects of medicines are unbearable, and also to open blockages in the intestine or to remove diseased parts of the intestine. Most people with Crohn's disease have a normal lifespan. It usually relapses or recurs without maintenance treatment. Hence, maintenance therapy is very important. Some people can remain disease-free for years or decades. Two commonly used antibiotics to treat infections, often as a result of the complications, which was discussed earlier, are ciprofloxacin and metronidazole.